Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
Welcome back to the Cribsiders. I'm Brian Ward. I'm joined tonight by Angela Y. Zhang and Sydney Engel. Say hi, you two.
Hello!
Hey, y'all.
We are back with another Fables from the Crib Side, our show where we review and recap top insights from previous episodes of the show.
Just to give you a reminder, we are the Pediatric Medicine podcast. Usually in this show, we interview leading experts in the field to bring clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
Today, instead of a conversation with one expert guest, we're taking a look back at 3 of our prior episodes with a focus on some common pediatric endocrine disorders. We'll be doing a spaced repetition recap of top pearls about short stature, puberty, and hypothyroidism.
So without further ado, let's get to it. Okay, and the pun. It was really hard. I'm excited to learn about hypothyroidism, even though I think I've learned about it T4.
I love
Did
it.
you get it like before?
I really like it.
It's such a dad joke.
Good timing.
I appreciate it.
Should we do some quick picks of the week before we jump in?
Sure, Sydney. Why don't you start as you had the suggestion?
That is cruel. All right. My pick of the week, I just finished the book The Wedding People by, I don't know how to pronounce her last name, but Alison Espach. Anyway, I don't know who recommended it to me. I just Googled it, and turns out it's like a Goodreads top book of the year. But it was one of those books that showed up in my library queue, and I was like, sure, why not? And it totally took me by surprise with how both funny and profound it was. And it's been a while since I've read a book that I really got hooked in that way, and I went away saying, okay, I'm going to remember this book for a while. So it was just a nice escape from something that is both very deep and very delightful.
All right, I'll go next. I just binge watched this 8-episode series from Netflix called A Man on the Inside. It has Ted Danson, and it's like from the same people that made The Good Place, if you watch that, which is
so
just such
good.
such a feel-good show. Also big twist in the first season of The Good Place. And this one, I felt like it's centered on like a mystery. This elderly resident in a nursing home's watch gets stolen. And so Ted Danson takes a job to be on the inside, if you will, of this nursing home. It's actually based on a true story, but it was much heavier. In the true story, they were investigating elder abuse and were moles in the facility, but obviously this one's much more lighthearted. And I feel like it kind of reels you in, like in the first couple of episodes, kind of set up and him learning to be a spy, and it's like really funny, and you meet all the characters, and they're all like older actors, and then just like it just hits you like the second half of the series. It's a lot about like aging and parenting and relationships and just how we're like all in this life together and just living it. So I would recommend, but I would give yourself time, because I said, I'm going to only watch 2 episodes. And the next thing I knew, I was done.
Oh man. All right. I can't wait to binge this show when I have the time for it.
That's awesome. All right, I guess I'm up. In the short time that I've been reading, I've read a little bit of, this is so strange. My neighbor wrote a book and published it, and I'm actually really enjoying it. It's called Stupid Fast, and it's just very young adult novel-y. And sometimes you just need like a young adult novel. It's about a high school cross-country team, which was the theme of my high school years. And thinking about this episode, it really brings me back to puberty and all of the emotions of that. But it's really fun. So in general, my pick is young adult novels.
They're so good. My friend
really
who's a
are.
librarian actually was like, YA often pushes the envelope a lot because they kind of have this freedom to, and it's a separate conversation about like what is good literature, but they're not usually in these contenders and like critical, like, review editor choice awards. And so they just get to like experiment and make these like amazing books, and have also changed a lot since we've been teenagers / young adults.
They're under the radar. Well, speaking of below things. Do you want to start with below the growth
Wondering
curve?
where you were going with
off
this.
the cuff, audience.
Oh my goodness.
We did not write that into the script.
All right. Well, I guess if we're going to make such a smooth transition, we can jump into our first recap episode. I'm going to start us off with our recap of episode number 70, which was on short stature. Our guest for that episode was Dr. Lori Cohen, and our producer was Dr. Maggie Ivanova. So, short stature. I feel like this is the sort of thing that comes up all the time in primary care pediatrics. We're dealing with patients who are coming in concerned about their height, or we're monitoring the growth chart, or we should be monitoring the growth chart, and seeing patients that just aren't following the curve the way that we want them to. And so this episode to me was very much full of pearls. So just starting off in terms of what is short stature. The way that Dr. Cohen framed it is, and I think the standard definition is more than 2 standard deviations below the mean for age and sex on a growth chart, which would put it right about below the 2.3 percentile. So that allows you to kind of diagnose who would be there, although of course you're also looking at the trajectory for the particular patient. And she did highlight that we should be using the appropriate charts for patients with trisomy 21 and Turner syndrome. And then the charts change, as most primary care pediatricians will know, between between less than 2 and older than 2. Less than 2, it's the WHO one. Greater than 2, we use the CDC one. And one thing she highlighted is that the CDC chart was created specifically from a group of white infants in Ohio between the 1970s and 1990s. So when we're thinking about, where kids fall in those charts, it's important to acknowledge that their background may or may not be similar to that.
Yeah, and I thought it was really nice actually to have that, you should use the CDC, or you should use the WHO instead of the CDC for these reasons. Sometimes I find myself in clinic debating which one to use. I also didn't know there were disease-specific or condition-specific growth curves. Something that I wanted to just point out is our guest in the episode, if you listen back, she says the growth charts are based on age, sex, and actually race. And I think we just wanted to highlight that because you might listen and wonder where that fits into practice. And I did a quick literature review. There are, quote unquote, studied parameters of growth based on race, but as we've talked about on this show a lot, race is social and dynamic, not biologic and static. And so, and we know that height is really polygenic, right? She even talks about it in this episode. And so I think we would really advise against using any sort of race-based parameters and rely instead on all of your other excellent clinical judgment, maybe family history, which we'll get to.
It seems like family history would be a better way to get at the more specifics of the patient and do a more personalized approach instead of generalizing by population. Sydney, did Dr. Cohen talk about mid-parental heights, which is something that I feel like I've used before in clinic?
Yeah, she did. And I will say that many EMRs, including the one that I use at my clinic, have a way to put this in, which is so helpful just for those of us that don't want to be doing math while also simultaneously trying to field 3 questions. But if you don't have a built-in calculator, mid-parental height, which is a nice predictor of a child's maximal height, is for people with ovaries, it would be dad's height minus 5 inches, averaged with mom's height. For people with testicles, it would be mom's height plus 5 inches, averaged with dad's height. And then, of course, we're thinking about there being 2 standard deviations being normal, so it would be plus minus 3.5 inches from there. And as mentioned, this is polygenic. This is not going to be a perfect predictor, but it can be a good way to start of saying, is this child reaching their height potential? And is there, what height do we predict that they would be when they're kind of asking us and looking ahead?
And then looking about kind of the whole patient, you kind of start to look at the review of symptoms, right? You see what else is going on to beyond just the personnel, the family history. This rings so true to me. I actually, as a kid, was a little bit short, and my pediatrician was following me closely on the growth curve and then did a great review of history or review of symptoms. And I was diagnosed with IBD primarily based on short stature on a growth curve. So this is not just constitutional growth delay or delayed puberty, like we'll talk about a little bit later, but this is going to catch a wide variety of diseases.
I love that you have that personal anecdote there because I do think that that's something that Dr. Cohen brought up that really stood out to me is how important the review of systems is, and that height can be the first and sometimes only presenting sign of something underlying. And so, again, plug for following the growth curve, but asking about GI, neurologic, cardiac symptoms, as well as the symptoms of hypothyroid, which we'll go into later. Again, GI symptoms can be absolutely silent, but that can kind of help you to go on a specific trajectory there.
Yeah, growth curve is definitely a vital sign.
Yeah, especially because kids, they need nutrition and they need to grow. So it's interesting that it affects height for sure. Kind of speaking about measuring that and actually thinking about the curve, I think we've all heard in clinic, it's really hard to get a height on a baby, for instance, because they're wiggling. But once they can stand, that's when you can start to have accurate heights. And I remember being a kid in clinic and, they get your height and you like stand up really straight and you kind of like tilt your head a little bit and they give you that look and you like tilt your chin down, So what exactly should we be looking for when we think about, okay, what is a good technique we can measure height for? So either providers or we can teach our MAs.
Absolutely. So I think if we're talking about height as being a vital sign, it's only as good as our measurement technique. So obviously, just like with blood pressure, where you need to be measuring it appropriately in order to be able to trust the outcome, we need to be thoughtful about how we're measuring height. So I feel like, Angela, whoever was your pediatrician did a really nice job, or the MAs at the pediatric office, of making sure that you had your head straight. So having the child standing, looking straight ahead, their legs straight up against the back of the stadiometer. You want it to have a movable head that you can then make sure is at 90 degrees. And then if you're measuring a baby, you want to do them on a length board where there is that fixed head, and then you can essentially stretch them out to reach that point on the board. She did mention measuring at least 3 times, which I think is also a very good practice to get into. I don't know that I can say that that's done consistently in my clinic, but it's something that I would like to do because, again, if we're really going to be trending this and following this as a sign of something going on, we want to make sure that we're working with accurate numbers. I also just want to touch briefly on some of the other physical exam findings she touched on. So I guess beyond literally their height, there are the things related to the thyroid disease that we were talking about. Also, the thyroid exam itself, deep tendon reflexes. They're the dysmorphic features you might look for, frontal bossing, looking at the nasal bridge. The big one that stood out to me is she was talking about wanting to look at kids' limb length and arm span, because shorter limb length along with short stature can be really the presenting finding in chondrodysplasia. I don't think I have honestly ever measured a kid's arm span, but I think that it's something that I would like to start doing based on this episode, again, because I feel like it's our job in primary care to catch the things that are subtle and we wouldn't find otherwise.
That's fantastic. I mean, the measure twice, cut once was what she brought up. And I love that. I love that. What buckets would you put some of these delays in growth in? I think she talked about buckets, right?
Yeah. And I my brain works really nicely whenever anything is categorized. So for me, this worked very, very well. She was talking that there are basically 3 main possibilities when you look at short stature. The first are what she calls intrinsic causes. I would think of that kind of as a primary short stature. So it might be due to intrauterine growth restriction. I guess maybe primary isn't the right way of looking at it, but it's something that causes short stature in and of itself. And so something monogenic like Turner's disease, achondrodysplasia, also like familial short stature and constitutional delay would go into that bucket. With those ones, the weight pattern varies, so that's not a particularly helpful distinguishing feature, but it is for the other 2. The second bucket are things that affects the nutrition adequacy. Essentially, if a child isn't getting adequate nutrition, they're not going to grow to their full potential. So that would be things like any of these GI diseases, type 1 diabetes, and then actual malnutrition. And in those cases, usually you have a decreased weight to height ratio. And then her third bucket was endocrinopathies. So that would be your hypothyroid, your growth hormone deficiency, Cushing's disease. And usually those will have either preserved or accelerated weight gain.
Something that's really interesting, Sydney, is actually that part about the steroids. We're in the peak of respiratory season right now in my practice, and I'm thinking about steroids a lot. And although there is no, it sounds like, defined limit over, which you have the increased risk of short stature necessarily, it was interesting that our guest talked about both inhaled and oral steroids. And I feel like the takeaway is probably we don't totally know how much like a lower dose or inhaled steroid might affect your growth. It's important to treat asthma if your patient has it or wheeze, but also to be in that vein, judicious about your steroid usage for other respiratory things like bronchiolitis, or maybe, judging if it's viral wheeze or judging if it's true asthma. So I thought that was really interesting.
Absolutely. I think that that's one point that I hadn't thought about at all that really stuck with me. So jumping from those buckets into okay, so what the heck do we do when a kid has short stature? So sometimes there's absolutely nothing that you need to do. If the kid has short parents, if their growth trajectory is pretty stable, especially if they're not even below that 2.3 percentile, sometimes it's a matter of just monitoring. The next workup that is typically ordered would be a bone age. And worth noting that although we can certainly order it in primary care, the endocrinologists do usually like to be able to see the film itself, or at least that's what Dr. Cohen was saying. And so it ideally would be in a situation where the endocrinologist would be able to get access to the actual images. Regardless, it's a good measure to be able to detect constitutional delay and just kind of understand if there was an insult at a specific time. Basically, if it is more than 2 standard deviations delayed from their age, or either delayed or accelerated from their chronological age, a pathology is going to be more likely.
I love the little tidbit that you can measure the knees too, because at the end of the day, it's just a book where they look at the standards, and they have standard knees for babies where the hands just isn't ossified enough to get an accurate measurement.
Although I will say I was thinking about that today when I had a kid with some signs of premature adrenarche, which we're going to get into in a second, who was very young. And then I was like, okay, but if I order this, is the radiologist going to think I'm crazy? So I have questions about that, but I did love that pearl.
I also just like to say that I love that she said you should bring a CD to your endocrinologist. I wonder what percentage of office supplies remaining CD stock is going to transportation of medical images.
Probably the same
Cashlack
percentage.
in Tennessee does. The Cashlack Children's Hospital in the Southeast certainly does.
I would say that fax machines and CD-ROMs are kept alive by the medical industry. So, additional workup. The other things that she would check, so in addition to the bone age, especially if they're dropping percentiles, but their weight is not dropping along with it, she would almost always be checking a CDC, CBC, a SED rate, a thyroid, and then she would screen for growth hormone deficiency. The challenge there is that growth hormone itself is pulsatile, so you really can't check for it because you could be catching it on an upward or downward part of the pulsing. So usually she would be checking the mediators, which are IGF-1 and IGF binding protein. She did go into some of the distinctions there of which the limitations of it, but general idea is that both of them are worth getting because they each have a little bit of limitations, and that you can have a complete deficiency, but if you have the lower end of normal, you may also be finding a partial deficiency. And then finally, she did touch a little bit on MRI. Basically, the takeaway there was that the likelihood of the MRI having a lesion is generally pretty low. If there's significant growth hormone deficiency, those are the cases in which she would proceed with ordering an MRI. All right, well, let me, speaking of growth hormone deficiency, I want to talk about treatment for about 2 seconds, which is just to say that a lot of families do wonder about growth hormone, and she touched a little bit on it and on kind of highlighting that there are in contexts in which it absolutely makes sense. If there's a true growth hormone deficiency, it's going to help them to reach their genetic potential. If there's a partial deficiency, potential benefit. Other cases or other causes, probably not so helpful. And then there are some potential side effects with it. And then the long-term risks of it are really not known because it hasn't been in use for long enough for people who have received growth hormone injections to reach an older age.
Our patients' bodies are changing, and so is our episode topic. You listened to the puberty episode. This was episode 56. What do you want to tell us a little bit about it?
Yeah, so this is a bit of a throwback. Episode 56 in season 4. Our guest was Juanita Hodax, and then our producer was Jelena Castillo. This is such a universal topic for anybody seeing patients in clinic. So we'll maybe go over some general pearls first. So thinking about just some really great clinical tips that Dr. Hodax had. The first thing I thought she said really well as a standard in the conversation was that she never used gendered terms, and she always used terms like a person or a child with ovaries or a person or child with testes. And I think you can tell that she does this so often, and she really destigmatizes these words for her patients. I also thought it was a really good tip to do the annual GU exam between ages 7 and 14. I'll be the first to say that it is, I don't always do it every year because it ends up being a little bit of a touchy topic when I bring it up. And I've always wondered, like, at what point do we say this is important? Maybe next time expect to have this exam, or the strategies for that, which are a bit outside the scope of our conversation, but just drove home, why it's important to do that exam. Because not only are we looking for lumps and bumps and all those things, but we are able to assess if they're in puberty or not.
Yeah, what I found was shocking was the distinguishing between adrenarche and puberty. And so when I thought about puberty, I thought about it all as this one big, wild and crazy time. But some of those things like body odor and skin changes and acne are more related to adrenarche and were separated a little bit from puberty.
One thing that I don't know if it was like a big pearl from this, but when we were talking about the annual GU exam, I think that I really appreciated the distinction that was made of like, okay, here's the thing you really need to know. You need to know when they're Tanner 1 to 2, when they're making that transition, and then when puberty is ended at Tanner 5. So does it really matter if they're exactly 3 or they're exactly 4? Not really. But again, if we're trying to understand if it's precocious or delayed, we really need to know, have they started those pubertal changes?
Exactly. I think it takes a little bit of pressure off. It feels less academic and more puts into context of, okay, what am I really looking at here when doing the Tanner staging? And she talks about the typical ages of onset of puberty. So people with ovaries, it's about ages 8 to 12. People with testes, about ages 9 to 14. And a couple other things in this age range are that the growth spurt happens in the second half of puberty. And so patients, kind of referring to our last topic, are saying, I've started having some signs, but I'm not growing yet. When is that going to happen? I think you can have a better answer for them. I also think it was interesting that she said, puberty happens over the course of 2 to 3 years. And so if the changes are happening too fast or too slow, then that is can also point you towards something that you might need to work up more, which we'll discuss in a little bit.
Angela, can you tell us a little bit, if we jump into one of those, pathologies that you mentioned, can you tell us a little bit about what Dr. Hodak shared about delayed puberty?
Yeah, totally. So we kind of refer to these in lay language as the late bloomers, right? But the most common cause of late puberty, and we're talking about signs of true puberty, like Brian said, not adrenarche, but really the central stimulation. The most common cause is constitutional delay. So maybe things like family history. So you ask, when was your parents' first menses? Do you remember when the other parent had first sense of puberty? Or things like malnutrition. Some other important history questions that might point you towards a more central cause of late puberty, such as like things with the pituitary, would be if their other hormones and downstream effects are affected. So have they stopped growing in height, which might point to growth hormone? Do they have signs of hypo or hyperthyroidism, which we'll talk about? And that would signal a problem more so in the central portion versus the peripheral.
And to that point, Dr. Hodak's kind of said that even though constitutional delay is the most common cause, if a child is reaching, she said about a child with testes is reaching about age 14 without signs of puberty, that it makes sense to go ahead and do a lab workup. I don't remember what age she said for children with ovaries, but I think it might be a year earlier. Regardless, that would include in the morning LH, FSH, testosterone and estrogen, and then potentially other things like TSH.
Yeah, I think that speaks to, how important it is also to have a continuity provider who can set that up, like, hey, this year, let's just keep watching. And then when do you really, say, okay, today's the day we do labs? And they had a really good conversation about that. On the flip side, kind of moving on from late puberty, the other end of the spectrum is precocious puberty, or puberty that is too early. And so we had a really good conversation about this in the episode. The first is that it's more common for people with ovaries to have sort of idiopathic precocious puberty. So the onset would be between 6 and 8 years old. We did talk a lot about racial inequities. This is something that I learned in medical school, that Black girls in particular are more likely to have precocious puberty. And so if a Black girl comes in your clinic and she's younger than, she's in that 6 to 8 range, I was taught that it might actually just be okay, that it might just be how her body is. And like we've discussed at the top of this episode, because race is not static or biologic, that's pretty problematic to assume that it would be normal and you might underdiagnose somebody. And so there's a lot of research in this, both from medicine and from other fields, but most likely we're thinking that it has to do, we do see early puberty more in children of color, but the reason is not biologic. The reason is that there are things like weathering, like toxic stress, even environmental racism with different ingredients in personal care products, or even chemical, environmental pollution kind of around them in red line areas.
That's so important to keep in mind, to figure out, okay, what do I do here and how does that relate to the broader society? I thought it was interesting thinking about when I'm working up patients, when am I expecting something to be wrong? And it seemed like below the age of 6, you're more likely to find something beyond that constitutional pubertal delay or the quote unquote late bloomer. Beyond or below the age of 6, precocious puberty is more likely pathologic. It begs the question for me, where do you localize the problem? And it seems like it was between the pituitary and somewhere else, Angela?
Oh my gosh, yeah, I really had to, in my mind, do some gymnastics around the feedback loops, but I think I got it. So if you have a kid, for the age of 8, or in this case, you think below the age of 6 is certainly more concerning. First, kind of by type of test you might do. And you can do this as a PCP, right? You would probably start with some basic lab work, some LH and FSH and testosterone. You can't measure the GnRH. And the important thing is that in early puberty, it's a diurnal pattern. So like with many of the other labs, you want to check first thing in the morning. And that would give you more data on whether it was central or peripheral. So for a central, you would have lower levels of LH and FSH because they're not able to make the hormone. But if it were peripheral at the level of the gonads, you might have higher LH and FSH because the gonads are not responding with their respective end hormones. We talked about bone age and the x-rays. You can assess growth potential through this. We talked, I think we talked pretty much enough about it in the short stature part, but something that was interesting that Dr. Hodak said was, who looks at it? And I thought that was interesting was that the pediatric radiologists sometimes read it, but really, again, it's like a pediatric endocrinologist. So having good records and making sure it's all in the same system, or you have that CD. By the time you get to imaging, though, I think you'd probably refer to endocrinologists. I think if you can order and read a brain MRI, then I am super impressed with you as a general PCP. I don't think it's impossible, but certainly I think many people would be referring at this point is getting a brain MRI if you're thinking about something central. Something like a brain mass, something like Kalman. If you remember from your board studying, those are kids who can't smell. Sometimes you can see the lack of the olfactory bulb on imaging, which is a nice pearl. And then, she kind of talked about these different names for these buckets. And this is where I had to really sit down and write it and think about it. But you have the hypergonadotrophic hypogonadism, where you have the high LH-FSH and low testosterone. These are things like Klinefelter's or different iatrogenic ways affecting the gonads. Or you have hypogonadotropic hypogonadism. And I think if I explain any further, I will think myself into a corner. So I will stop there.
Angela is doing the eyes up to the corner of the room. Let's remember those images we drew in medical school where it's, which is the feedback loop. The thing that I found interesting is even, if you, these endocrinologists are so smart, and sometimes they just give some testosterone to see if it kickstarts the system. And I thought that was fascinating. The body, once it gets a reminder of what to do, sometimes just does its thing.
Yeah. Totally. Someone just needs a little bit of a reminder, to get up in the morning like the rest of us.
What about precocious puberty?
Like treatment-wise?
Yeah.
Yeah, I think this was, I think this is a pretty, honestly, pretty relevant topic right now. So the treatment for precocious puberty is a puberty blocker. So these can be injections or they can be implants. They're actually much of the same that you use for gender-affirming care. So we have to think about the different ways that we use these blockers for different conditions in kids. And so the endocrinologist would probably initiate the puberty blocker. I would certainly be referring at this point, but they wouldn't. I feel like in some cases they may give growth hormone and kind of replace, give more of the hormone. But in general, I think they just choose to block it until they get to a good age for puberty. Also considering the psychosocial aspects of going through puberty early, kids can be mean sometimes. And I think it would be kids I think have trouble standing out in that way at a young age.
Young adult novels, they come back again. Well, let's goiter, our last topic.
Brian is carrying the team right now on puns. I just
Oh
like
my
to say.
gosh, his dad puns are just so good.
They just come to me in the dark of night. They just strike me. Well, our last topic is hypothyroidism. It's actually had some ties to every single one of these. These episodes are so well tied together.
It's
But this
almost
was
like we planned it that way.
Well done, Sydney. This was episode 78. This was with Dr. Megan Fredette as our fantastic guest. And the Dr. Maggie Ivanova was, again, the producer on this one, has a theme of endocrinology. I loved this episode for a number of different reasons. It had some wonderful pearls. For me, it all starts with the newborn screen, though. I always wondered why they made such a big deal about the newborn screen. But after listening to this episode, I was reminded how important T3 is for neurodevelopment. And so it's critically important to catch congenital hypothyroidism, which was probably the main focus of this episode. It's important to catch congenital hypothyroidism very early. And then about after the age of 3, Dr. Fredette started talking about how it's less of an issue for neurodevelopment, but you definitely have some growth deceleration and then some quality of life concerns that we'll talk about in a bit. The newborn screen is set up to be very reliable, but it depends on the type of screen that your state has. And so there's a T4, a free T4 screen and a TSH-based screen. And I think it's worthwhile just looking up which state you happen to live in for that.
I found when she was talking about the newborn screen, one of the most helpful things that she shared was just explaining why a kid might screen positive other than having true congenital hypothyroidism. So she was highlighting that in normal infancy, there can be a transient TSH rise. And so if that newborn screen is drawn too early after birth, you may get that false positive. Additionally, in a preemie, that TSH rise may be delayed. And so if you screen at the wrong time, you may miss it or you may catch it at that particular moment. And so I think it highlights the importance of the repeat screens. And I think for me, a lot of times when I do have a positive newborn screen, the parents start freaking out. So it's very, very helpful to be able to talk to why there's the possibility of a false positive or a falsely abnormal results there.
But even with those falsely abnormal results, it sounds like we err on the side of caution because thyroid is so important for neurodevelopment, and a little bit of extra thyroid hormone is not the worst thing. We err on the side of caution and give levothyroxine if there's a mild elevation. I was impressed with the latitude that Dr. Fredette said a primary pediatrician could have for this. And Sydney, it sounds like you have a decent bit of experience managing congenital hypothyroidism in your own clinic. And so it seems like if we have a screening TSH that's between 20 and 30, it's worthwhile repeating. If the free T4 is okay and the TSH is 9 to 20, you can follow it down. If the free T4 is not okay, you start levothyroxine, and then you start it at 10 to 15 micrograms per kilogram per day. That was a really confusing way to say it. Ultimately, if it's a mild elevation, it's worthwhile starting. If it's a major elevation, usually the endocrinologist is involved. If you don't know what to do, the endocrinologists are always so happy to help.
I will say one thing about kind of those early results. I think one thing that surprised me here was in the case, it was, I think, a 10-day-old newborn where they were looking at those newborn screen results. And her thought was like, you need to start this kid right away. That in that period, because T3 is so critical for neurodevelopment, literally every day matters. And so to your point on kind of it, caution in this case is starting the levothyroxine. I think for me, it made me feel a little bit more like, okay, if I'm trying to make the most judicious choice here, it's not to watch and wait. It's to go ahead and start something.
Even if you just give a couple doses before the results come back and they're negative and you can stop.
Yeah. But it sounds like getting those doses into the baby is incredibly challenging.
Yeah, I loved, this was such a great part of the episode. I think, especially in pediatrics, I think so much about nuts and bolts of, okay, we give this recommendation. How do you really implement it? I think we all were around, and the pharmacist would bring by different medications for you to try. And I have my personal favorites and most disliked, but I loved how she talked about, how are ways you can actually administer levothyroxine to a baby. And it was things like, I think her personal preferred method is just to crush the tablet between 2 spoons and just take a fingerful and put it into the cheek, kind of at the expense of palatability. You make sure they get the full dose, kind of referring back to the neurodevelopment. And things not to do would be to mix it with the formula or the breast milk in the bottle. And I think, so much of the time, and I'm certainly guilty of this, is I just say, take the medicine. And then some other like wonderful nurse or MA or pharmacist is the one actually sitting down and giving that advice. And so I think, we think about equitable care. We think about, okay, the baby has to get the full dose. What barriers are there? What like literacy barriers, what language barriers are there? What physical barriers at home, right, might be in the way of getting that medication into somebody?
And it's pretty important because we're talking about cutting pills in half and doing this interesting dance of, if I cut a 250 pills in half, if I cut a 75 in half. All right, we talked a little bit about the TSH and T4 in the newborn screen. I'm going to try my best on the audio format to talk about the thyroid axis because it was helpful for me to think about what tests I'm ordering and what tests I'm waiting for somebody else to order. The TSH is produced in the pituitary and comes down and stimulates the thyroid to do its thing. The thyroid produces T3 and T4. T4 can be bound to thyroid binding globulin. And so when thinking about what tests are most helpful, it seems like the TSH coming from the pituitary is a pretty sensitive marker. It's like the gas pedal. So if it's up, the thyroid is not doing its job typically, unless you have central hypothyroidism. And then the free T4 is typically measured on the newborn screen as along with the TSH. Like I said, it depends on the state. And Justin Burke said it's, quote, like an iCal. So it is the T4 that is not bound, and it's the one that's easier to test, a little bit more active. And so if you have a question about what's the thyroid doing, the free T4 is the most tried and true method to see what hormone the thyroid is putting out into the periphery. The total T4, there's so much that's bound to thyroid binding globulin that it can go up and down depending on other conditions or environmental factors. A low thyroid binding globulin can make the T4 total look abnormally low, but have a normal free T4. If there's exogenous estrogen or estrogen being produced endogenously, like in the beginning of pregnancy, you can have a total T4 that's high, but a free T4 that's low because you're producing a bunch more thyroid binding globulin. And then there was a condition I hadn't heard of before called thyroid binding globulin deficiency, or TBG deficiency, where the T4, what was it? The free T4 is normal, but the total T4 is low. I think I got that right.
Yeah, I think that just speaks to how important the free T4 is, and the total T4 might not be totally relevant. I will say this was on my boards, which is the only reason why I know it, in my board studying, and I had also never heard of it, but I think it's just one of the many reasons that a total T4 isn't that helpful.
Absolutely. It seems like the T3 is sometimes good for the endocrinologist to follow in very hyperthyroid states. A free T3 is rarely used. Dr. Fredette said, let that one be. I've ordered it once in my whole career. And so if an endocrinologist is saying that, then I'm never going to order it. But then there are some antibodies that are important to order, especially if you're concerned about acquired hypothyroidism or thyroid deficiencies that are crossing the placenta. TPO is the most sensitive. There's also antithyroid globulin. Thyroid stimulating hormone is for hyperthyroidism and Graves' disease. And then there were 2 other acronyms that I'm not going to spit out here, but there's more in the show notes. Again, this was episode 78.
Brian, can you talk a little bit about, okay, so we have a baby with hypothyroidism. What are we thinking might be causing that congenital hypothyroidism? And then what workup do we need to do to figure out the cause?
Yeah, certainly. By far and away, it seems like the most common cause is congenital dysgenesis. So 85% is either aplasia, dysplasia, ectopic. The thyroid is not formed where it needs to be. It's a location or it's an actual thyroid hormone not forming issue. And eventually you'll want imaging, but you don't need imaging to treat. Ultrasound can be helpful, but it might miss if the thyroid is, for example, like a lingual thyroid. But a nuclear study can also be helpful, but might miss if you've got thyroid inhibition, for example, from maternal antibodies or antibodies delivered via pregnancy. So it seems like if you've got hypothyroidism, we're going to treat is most likely a thyroid dysgenesis, and a combination of studies depending on the clinical setting is most helpful in terms of ultrasound versus nuclear.
Do you want to talk just very briefly about what the differential is? If you say 85% is dysgenesis, what are the other possibilities?
Yeah, the other ones could be thyroid dyshormonogenesis. So you've got the thyroid in the right spot, but it's not producing thyroid hormone. And then the one that I thought was very important is central. So central is typically a pituitary problem. You're not producing thyroid hormone. And so then your thyroid is not stimulated, you're not producing TSH. So then your thyroid is not stimulated to produce thyroid hormone. This is more rare and associated with other pituitary insufficiencies. So I look out for other endocrinopathies. But most importantly, you can have a low TSH. And so it might be missed or misdiagnosed if you're only getting a TSH. There are also some transient causes of congenital hypothyroidism, mostly blocking antibodies that cross the placenta during pregnancy. You can also get a transient elevation with Graves' disease. Again, most of these antibodies are going to be IgG, and so they should cross the placenta. And then there's some idiopathic, we don't know what's going on in there, as there is in every bucket.
And then do you want to talk a little bit then, so those are the congenital causes, what you're thinking about with, I don't feel like she went as much into the acquired hypothyroidism, including like when you would be doing the workup, but I think we actually kind of touched on that in some of the earlier episodes. So can you just talk a little bit about that topic?
Yeah, we definitely did in the earlier episodes. Autoimmune is the most likely cause of hypothyroidism later on, typically adolescence or beyond. But as we talked about with the short stature and puberty episodes, thyroid hormonopathies can happen earlier, and they're usually autoimmune. You're looking typically for a family history, though that's not always necessary. And then they get more likely as you get older.
Yeah, one place I really felt like I saw this a lot was, so autoimmune thyroid disease can run with other autoimmune diseases, in particular celiac and type 1 diabetes. And I think maybe they might test kids with trisomy 21 also, screen them for thyroid. And another pearl that she gave towards the end, but I actually think ties in really well here, is that oftentimes you're seeing these new type 1 diabetes patients in DKA. So they're quite sick. Sometimes they're in the PICU. Sometimes they're on your floor getting ready to go home. And the admission labs include, because of the, running together, include screening for celiac, for hypothyroid. But a really good point in this episode was that there is something that is like sick euthyroid. So, or in other terms, it can look abnormal. The thyroid function can look abnormal, but it should recover after they are well. And so in general, we actually don't check for thyroid function tests when a patient is sick. They'll probably just get rechecked at their endocrinologist at their first quote, well visit for their diabetes.
Yeah, that's a great point, because a lot of these endocrinopathies are grouped. The other pearl that I thought was really cool was talking about adrenal insufficiency. And so if you have a patient who is having trouble gaining weight, and maybe has some hyperpigmentation, has some morning nausea or something like that, and you're thinking about adrenal insufficiency, it might be worth checking an AM cortisol, because if you have somebody who is in a low metabolic demand state with hypothyroidism and you give them that thyroid hormone back, that might chew up the last bit of your adrenal hormones of adrenaline or of cortisol that you have in your body, and then could kind of push them over the edge into adrenal insufficiency, which is kind of scary when I started thinking about it. It made me think more about my physical exam. How often am I really looking at pigmentation? Or again, how often am I looking at these growth curves to make sure that this kid is not truly losing weight?
Yeah, that one was terrifying to me and definitely made me say, okay, with every kid with a concern for hypothyroidism, I need to check for their weight changes, their pigmentation, and then ask them about things like vomiting in the morning.
If you do feel comfortable starting, the dosing is a little bit lower for adolescents and adults. It's typically 1.6 micrograms per kilogram per day, but it seems to be very much titrated based on the TSH and T4. And it seems like the endocrinologists take a good firm handle on that. I have not started thyroid hormone in my Gen Peds clinic. I'll talk a little bit about the hypothyroidism symptoms, just speed through them as a reminder, and just touch on one last pearl, and then we'll be done. I think a lot of us learn these and they're fun. Being tired, having some weight gain, constipation, dry, brittle skin, short stature. These are things that we can easily miss if we're not doing good complete physical exams and reviews of systems. The one that I thought was really fun, well, there are two cross-reactivities that I thought were very fascinating. The Van Wyck-Grumbach syndrome and the galactorrhea pearl. So for Van Wyck-Grumbach, TSH and FSH share a common unit and can cross-react. And so if you have a patient with precocious puberty, but growth deceleration and a delayed bone age, it might be that they have hypothyroidism, their TSH is super high, and they have this weird eponymous Van Wyck-Grumbach syndrome.
Love you tying all of these endocrine disorders together with that. That's beautiful.
Isn't it great? And then we've got one endocrine system that we haven't talked about, the prolactin system. So the TRH, so it's upstream from the pituitary. A TRH can cross-react with prolactin in high enough levels and can cause galactorrhea, which is wild. I feel like there are other things that I've learned about, though, that they brought up in this episode.
Yeah, one of the other symptoms of hypothyroidism that I actually didn't know was that it could, maybe I learned in med school and then forgot, is that it can affect your cholesterol and your lipids. And so, in that way, we get universal lipid screening for kids 9 to 11 per the AAP. And it's something in the differential that I wasn't thinking about for if I thought, okay, what if I get my lipid panel back and it's high? We think about family history, think about diet and activity screening, but it sounds like hypothyroidism should also be in a differential. And then you should check the growth chart.
Exactly. And especially if you're worried about weight gain and energy levels. Anyway, I really loved all three of these episodes. I think they tied together very well. It reminded me that I needed to draw out the hormones for every single endocrinopathy and look at the growth chart for every single child.
Absolutely. No pun to check us out of this episode?
Oh no.
See if you can find one on the spot.
We can cut the massive gap of time right here while I think about it.
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We are committed to providing you with high-value, practice-changing knowledge. And to do that, like the endocrine system, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com.
A special thanks to our showrunner, Sam Mazer, and our wonderful social media team on Instagram, Facebook, Twitter, now known as X, and soon to be Blue Sky. I've been Angela Weising.
I'm Brian Ward.
And this has been Cindy Engel. Thank you and good night.